So HELLP syndrome. What is HELLP? Winstein 1982 came with HELP, H hemolysis, EL elevated liver enzymes, LP low platelets. These are multi-system disorders that can occur on its own or in association with preeclampsia. There is activation of the coagulation system causing increased deposits of protein fibrin throughout the body, resulting in fragmentation of erythrocytes. Fibrin deposits on blood vessel walls initiate clamping of the platelets, resulting in blood clots and lowering of the platelet count. These deposits decrease the diameter of the blood vessels, raising blood pressure and reducing the blood flow to organs. The liver is especially affected, with destruction of liver cells leading to abnormal liver function and a distended liver with symptoms of epigastric discomfort. Possible pathophysiology: causative agent, increase in volume, fetal presence, or decidual cell vasospasm, deficient vascular repair, idiopathic. Those are the possible causes. The exact pathophysiology is not known. So with those possible causes, we come to vascular endothelial disorder, platelet aggregation or consumption, fibrin activation or consumption, selective organic ischemia or insufficiency, then variable manifestations. HELLP syndrome presents antenatally in 70% of the cases, most usually in the third trimester, and in the postnatal period it occurs 30% of the cases. If HELLP syndrome occurs before 26 weeks, it is usually associated with antiphospholipid syndrome, APS. It also complicates 10% of severe eclampsia cases, resulting in high maternal and perinatal morbidity and mortality rates. The woman will present with non-specific symptoms, which include malaise, nausea, vomiting, epigastric pain. In severe cases, we may have hematuria and jaundice. If there is preeclampsia, there will be raised blood pressure and proteinuria. The symptoms are similar to that of an acute fatty liver disease, AFDL, and the blood test define the diagnosis. Signs and symptoms of HELLP: excessive body weight increase, pulse pressure increase, systolic pressure more than 140 but diastolic pressure less than 90, ophthalmic disorders, minor alterations, cortical blindness, that is amaurosis, retinal detachment, vitreous hemorrhage, elevation of biomarkers, this is HCG, maternal alpha fetal protein, serum aptoglobulin. The presence of these disorders in the hypertensive woman with epigastric and or right hypochondrial pain, nausea, vomiting, as well as hemolysis will help in marking the right diagnosis. Differential diagnosis: erythrocytic morphology, platelet disorders, renal compromise, hepatic disorders, immunologic disorders, genetic disorders. Complications can include progressive DIC, liver hematoma and rupture, placental abrasion, placental edema and adult respiratory distress, pleural effusions, renal failure. The main treatment is to expedite the birth of the baby, the management and delivery care being similar to that for severe preeclampsia. Emphasis should be on administration of magnesium sulfate to prevent conversions. The condition usually resolves, however, 2 weeks after the baby's birth. Management: anticipate the diagnosis, evaluate the maternal conditions, evaluate the fetal condition, control the hypertension, prophylaxis of conversions with magnesium sulfate, water and electrolyte balance, immunotherapy, management of labor and delivery, optimized perinatal care, intensive postpartum treatment of the patient, be alert for multiple organ failure, advice on future pregnancy. Evaluation of fetal well-being include determination of the gestational age, evaluate fetal well-being, NST, that is non-stress test, tolerance to contraction test, and the biophysical profile. Use corticosteroids between 24 and 34 weeks to improve fetal pulmonary maturity, neonatal pulmonary function, as well as the maternal and perinatal results. Controlling the hypertension. 80% of the patients with HELLP need control of their BP to avoid significant perinatal and maternal mortality and morbidity. Treat systolic BP when above 150 and avoid placental hypoperfusion, maintaining the systolic BP not less than 80 to 90. Hypertensive medications include hydralazine, labetalol, hydralazine bolus of 5 to 10 mg IV every 20 to 40 minutes. If ineffective and unavailable, use labetalol, nifedipine, or sodium nitroprusside. Labetalol. Initiate bolus of 20 mg IV with increases in dosage until a satisfactory BP is obtained, or up to a maximum dose of 300. Nifedipine oral, not sublingual, at usual dosage. Sodium nitroprusside, fast-acting hypertensive drug, venous or anarterial, can be used in hypertensive crisis when all other hypertensive medications have failed. Loading dose 0.25 micrograms per kg per minute, increasing up to 10 micrograms per kg per minute. Above this dose, there will be greater risk of cyanide intoxication of the fetus. When using, remember its photosensitivity and the rebound effect. Preventing conversions, we will use magnesium sulfate. Initial bolus of 4 to 6 grams IV, followed by a continuous infusion of 1.5 to 4 grams per hour, individualized according to the patient. Continue 48 hours or more postpartum until clinical and laboratory signs of improvement are obtained. If contraindications of magnesium sulfate exist, use phenytoin. Loading dose 15 mg per kg at 40 mg per minute with continuous monitoring of the cardiac function and BP every 5 minutes. The therapeutic range is 10 to 20 microgram per ml. Management of labor and delivery. When considering termination of gestation in a patient with HELLP syndrome, determine the gestational age, maternal and fetal conditions, fetal presentation, cervical maturity. Optimizing perinatal care. The main risk of the fetus for the fetus in pregnancy with HELLP is its prematurity. The use of corticosteroids decreases the morbidity associated with pulmonary immaturity in preterm babies. That is dexamethasone. Delivery should be in the center with capability of treating these children with a major risk of cardiopulmonary instability. Advising in future pregnancies, the risk of recurrence of preeclampsia or preeclampsia is 40 to 43%, and for HELLP is 19 to 27%. The risk of occurrence of preterm delivery is high at 61%. Conclusion: HELLP syndrome and its management still poses a problem in modern obstetrics. Precise diagnosis and early treatment in non-mineral corticosteroids such as dexamethasone may help achieve favorable maternal and perinatal results. So that's the end of our presentation and document. So I know we're conversant now with preeclampsia, eclampsia, and HELLP syndrome. All the best. Catch up, subscribe, and watch my next videos on midwifery, medical surgical, and any other course or any other subject of concern. If you have any suggestion, you can comment. I record the video and teach you at your comfort.